Okay, good evening, doctors. Welcome to our 11th session of MCQ-based discussion. So we have these lists of topics which we are going to cover today. So first, let's have a look at stress incontinence. Let me take you to stress incontinence. So we have actually two types of urinary incontinences. First is stress incontinence and second is urge incontinence. So let's have a look at both so that we can easily differentiate among these two. So what are actually the symptoms on the basis of which we can say it's a stress incontinence? It's most commonly in older women. We have seen this stress incontinence with painless leakage, with coughing, laughing, or lifting heavy objects. So there must be a stress. It's not mandatory that the patient must be, of old age, but it's most likely because of the weakening of the muscles, especially detrusor muscles. That are the muscles of bladder wall. So we usually see in older women because of the muscle laxity or the decreased elasticity of the muscle fibers. They usually have this problem based on the stress. Whenever they are in the stress, they can they can just have this painless leakage of urine, maybe because of coughing, maybe because of laughing, maybe because of lifting heavy objects. But for urge incontinence, there is no restriction with the age factor. Here the patient is having sudden pain in bladder followed immediately by overwhelming urge to urinate. Means as soon as she started feeling to urinate, she cannot control herself. Even she cannot, cover the whole passage towards the washroom. And in between on the way, she can just urinate during, walking. So that's the problem with the urge incontinence. So stress incontinence, that's a painless leaking. The patient is not going to have any problem, and it's just leaking. The patient can leak by herself at any point of time, but of course that should be aggravated by stress. So whenever there's a stress, the patient can urinate, but that would be painless. Let me enter Dr. Sab again. But for urge incontinence, we have to think about that the patient, there should not be any stress on the patient. Maybe the patient is on the relaxing state, but as soon as she has the pain and she wants to urinate, she cannot control herself. So that is actually, you can say that's the involuntary action that she cannot control herself. So what we are going to do for this stress incontinence, have patients stand and cough, observe for the leakage. Of course, once you are asking for the testing, you can ask your patient to cough, and by giving the stress to the patient, if the urine leaked, it means that she's having stress incontinence. But for the urge incontinence, of course, it's not associated with any kind of pressure. So, or any kind of stress. So what we can do this pressure measurement in half full bladder. We can always check the tone of the bladder. So we can go for the manometry. In manometry, we are actually checking the tone of the bladder wall muscles, and thereby getting an idea that on which pressure actually the detrusor muscles are feeling contracted, and because of the contraction feeling, the patient wants to urinate, and on which pressure the patient cannot control herself and the urine passed out, just during walking and all that. So this is how we are going to do our testing. So let's see. So what we are going to advise to our patients, those who are having stress incontinence, we can always ask them to go for Kegel exercises. Kegel exercises are the one where they actually do by herself, and it's very simple. They are just going to contract her lower abdominal muscles by herself, because all the lower abdominal muscles are voluntary muscles. They are under control. We can just squeeze the lower bottom part of the perineum, all the perineal muscles, all the lower abdominal muscles. They will contract, and you can hold the urethra inside, and that is the exercise which we ask the patient to keep on doing, maybe 10 times a day or 20 times a day, or maybe sometimes 50 times a day, like 10 times, 5 times. Yes, doctor.
These are lower abdominal or pelvic muscles? Pelvic lower muscles.
Pelvic plus perineal plus lower abdominal muscles, all, because you see, once you contracted the transversalis muscle of the abdomen, that's also contracted. So pelvic muscle, perineal muscles also included in that, and the lower abdominal muscles. So once you are actually performing the whole move voluntary action by contracting the muscles, so the whole lower abdomen muscle, which includes upper part of the pelvic muscle, and of course the whole pelvis, making the perineum of the female, so all of them will contract together, because all are voluntary muscles. Yes. So, but of course, pelvic muscles are the main one which are supporting the urethra.
The pelvic muscles.
Yes. So, or what else we can do with this stress incontinence? We can ask for this local estrogen cream, but local estrogen cream, will not going add much value to, especially this stress incontinence. It's just going to do what? It can just enhance the elasticity of the muscles. So estrogen is only going to act on elastin fibers, and elastin fibers will become more elastic in nature owing to the effect of estrogen. But as it's a local cream, so the effect will be there once the estrogen is there, and once the estrogen is removed or wiped out, the effect will go. So it's not, going to be a much added value to this, especially stress incontinence. And then, of course, we have surgical tightening of the urethra. We can go for this procedure. If there is too much laxity in the urethra, we can go for this surgical option as well. But most of the time, the patient may get benefit from the Kegel exercises. For the urge incontinence, of course, we have to train the patient how she can train her bladder. Say, for example, she used to use washroom as early as possible. There should not be a feeling of, pain, or there should not be a full bladder, because other than that, she will not hold the urine and the urine will just pass away in between the way. So what we can ask the patient that you just go to the washroom, even you don't have the desire, but keep your bladder empty, keep the pressure inside the bladder empty, so that, you don't have that much urge whenever you want to pass urine. And then we can give this local anticholinergic therapy. They are going to relax the detrusor muscles. So whatever we are giving, oxybutyrate, this dolterodone, this deriflunomicin. So what are the action of this one? They are just going to relax the detrusor muscles. So whenever there is relaxation, there will be filling of the bladder. And whenever the bladder contracts, detrusor muscles contract, there will be a urination. So what we can do, we can just prescribe this medication if the patient, after, despite being trained, and we have already asked the patient for the bladder training exercises, but in spite of that, the patient is not, having much benefit over these exercises, then we can go for this medical treatment. And of course, the last one, we can go for the surgical tightening as well. But again, the patients also usually don't prefer the surgical tightening. They usually get, benefit from medicines as far as urge incontinence is concerned, and they may get benefit from Kegel exercises as far as stress incontinence is concerned. So let's just have a look at the question here. Here the question says, a 35-year-old woman delivered her 5th baby by vacuum extraction due to prolonged second stage of labor 3 months ago. So her prolonged second stage of labor is the stage where the cervix is fully dilated. So the time period from where the cervix is fully dilated to the delivery of the head of the fetus is actually termed as second stage of labor. So whenever there's a prolonged second stage of labor, what will happen? There will be a continuous pressure of the head of the baby over the bladder. And because of the continuous pressure, say for example, you can leave, or even if your patient is on epidural, she's having epidural anesthesia, you may leave your patient for 3 hours if she's primigravida. But here she is multigravida, she's having her 5th baby delivery. So you can leave this patient for up to 2 hours whenever she's having on epidural anesthesia. You can leave the bladder, you can leave the fully dilated patient for 2 hours. So it's a very much time period, because the whole 2 hours and the whole 1 hour, the full pressure of the baby is there on the bladder, and maybe because of that, the later on the bladder, you can see the bladder can create problem. Like in this patient was having prolonged second stage of labor. She was fully dilated for a longer period of time. The woman was complaining of leakage of urine when she coughed, sneezed, or laughed. So stress, based on the stress, if the patient is leaking, it means that she is having stress incontinence. So just based on the symptoms, you can easily differentiate whether it's a urge incontinence or it's a stress incontinence. Here it's clearly mentioned that the patient is actually leaking upon coughing or upon sneezing or upon laughing. It means that it's a stress incontinence. Now the symptoms have started after delivery and persistent since then. So it may continue until and unless if you ask the patient to go for the Kegel exercises and all that. So it will continue. Of course, it may go if the patient is young enough, she can control. So which of the following is the most likely diagnosis? Do you think it's a detrusor instability or stress incontinence or urethrovaginal fistula or overflow incontinence? Overflow incontinence, even though if I have already used the washroom, I already urinated, but still there is a dribbling of the urine. So we can say it's an overflow incontinence. Detrusor instability, the bladder can urinate anytime because upon contraction. Or urethrovaginal fistula, so that's a very difficult term where the vagina is actually, the urine is coming out from the vagina. So that's a complication of the pregnancy. So here's nothing about like that. It's a clear case of stress incontinence. Why it's a clear case of stress incontinence? Because it's clearly mentioned that the patient is having stress. Upon coughing, sneezing, and laughing, the patient is actually showing the leakage of urine. And you know exactly, she is not old enough. see, she's just 35 years of old, but because of the prolonged stage of the labor, you have a clear reason why she's having stress continence. Other than that, stress continence you will always find in old people, not in young ones. But she has a case where it's a clear indication, then we can obviously choose this one. Okay, for the next one, we have to go for the theory first. Next, we have bacterial vaginosis. So all these pelvic inflammatory infections we can cover at once. So let me do this one, 313. Okay. So we have a term actually vaginitis, and in this vaginitis, we can see actually it's the inflammation of the vagina. So what are actually the types of vaginitis we are going to discuss here? So of course there are infections, there are bacteria, there are some fungal infection, there are some protozoal infection, there are some flagellated protozoa like kind of Trichomoniasis infection. So we can see these are the organisms which can cause the inflammation of the vagina. So, and why it's mostly occur, we have the reason mentioned here, because the vagina has some very useful kind of bacteria, and those bacteria are known as lactobacilli. So these, like in the gut, we have some useful bacteria. So same in the vagina, we have this useful bacteria, and they are termed as lactobacilli. So what they're actually doing, these bacteria are actually helping, in the making the lactic acid. So as the name indicates, lactobacilli, they're actually helping in the formation of lactic acid. And once the lactic acid is there in the vagina, the purpose of the lactic acid is to maintain the pH of vagina acidic. So normally we have the pH of vagina which is less than 4.5. So you can easily think about this one, that 4.5 means that acidic. So who is responsible to maintain the vaginal pH acidic? It's actually the lactobacilli. So lactobacilli, they are the helpful bacteria. They are responsible to form lactic acid, and once the lactic acid is there, so lactic acid will maintain the pH of vagina acidic, less than 4.5. Now what happened? In case of any infection, if the patient is diabetic, if the patient is on antibiotic use, maybe because of any reason, any pathology in the body, I'm taking antibiotic for that. But that antibiotic is not only going to act on useful bacteria in the gut as well, but they're also going to act on this vaginal bacteria as well. And because of the use of antibiotic, any kind of antibiotic, this lactobacilli will die. And what happened when there is no lactobacilli? There will be no lactic acid, there will be no one who is going to maintain the pH of vagina. And once the pH of vagina is acidic, it will help the vagina to resist against sexually transmitted infection. If the patient is sexually active, so of course the patient's vagina, it's going to resist with those infections if the pH is acidic. But once, because of the use of antibiotic, or maybe because the patient is diabetic, or maybe any condition in which this lactobacilli will die, then what will happen? There will be no one to protect the patient from sexually transmitted infection and opportunistic infection, which are usually don't do anything, but because of deficiency or because of the killing of the lactobacilli, they will start working on it, and the vaginal pH will become alkaline. In acidic pH, the action of these bacteria, sexually transmitted infections, is inhibited. So in order to, inhibit sexually transmitted infections, we will always want our vagina to be acidic. But once the vaginal pH is getting on higher side, like alkaline, because of the deficiency of the lactobacilli, because of the damage of the lactobacilli, then we are more prone towards getting infection. So here we have first infection, that is bacterial vaginosis. Vaginosis is caused by this Gardnerella infection. Here you can see now for exam point of view, for MCQ or recall-based MCQ point of view, what we will see here, we will see the symptoms and signs of the patient, especially the smell of the vaginal discharge. That will be a great clue for making the diagnosis, of course. And when you do the microscopic examination, if you find pseudo-hyphae, we know very well hyphae is the one which is the main precursor of fungal infection. If you're going to see the flagella is a protozoal infection. So on microscope, you can also easily distinguish that whichever infection is there. So it's very clear in your questions. You can easily get an idea of which type of infection is this one. So for bacterial vaginosis, for Gardnerella infection, we will see the patient is having vaginal discharge with fishy odor. So that's a very typical smell. And it will mention in the case like this, fishy odor, gray, white. When you do the saline prep, you will see clue cells. So whenever in the question it says clue cells, whenever in the question it says fishy odor, vaginal discharge, always think about this bacterial vaginosis, which is caused by this Gardnerella infection. And what you're going to give as a treatment, will give metronidazole. All gram-negative bacteria can easily cover with this metronidazole. You don't have to think about any other medication. Just give flagyl, just give metronidazole, and that is going to cover all gram-negative bacteria. Or clindamycin, those who are allergic to this one, you can give to clindamycin. So these two important points, fishy odor and clue cells on microscopic, if you see, just confirm that this is a case of bacterial vaginosis. For candidiasis, the infection is actually fungal infection. The organism is Candida albicans. This is the same infection which is causing oral thrush, oral candidiasis, and it's the same infection which is causing inside the vagina, vaginal thrush. Always remember, whenever there is a candidiasis, always look for the history of diabetes in your patient. So whenever the patient is saying diabetes on having this vaginal infection, always think about this Candida infection, because this diabetic atmospheric diabetes patient who are having this metabolic disorder, they are more prone in damaging lactobacilli. And again, once the lactobacilli are not there, there will be increase in the alkaline pH, there will be increase in the pH of the vagina, and infections are more, the infections are getting more and more in these diabetic patients owing to the damage of lactobacilli. So, but must remember, for the candidiasis, look for any history of diabetes in your patient. So here you can see, and the discharge is very typical discharge. The patient herself is going to say, I'm usually having a discharge which is very curdy, just like a curd. It's a white cheesy discharge. And of course, it is associated with itching. So patient must be complaining of itching, the vulvovaginal itching will be there. There will be a curdy white discharge. The patient is having history of diabetes. Think about Candida infection. When you do this microscopic examination, you will see, on putting this potassium hydroxide, you will clearly see pseudohyphae. So the hyphae is actually a term which we actually using just to represent the fungal infection. Pseudohyphae, it's again, it's a type of one of the fungal infection. Here you can see on vaginal culture. Of course, what you're going to give to your patient, you will give antifungals because it's a fungal infection. So we'll give antifungals. So you have miconazole, clotrimazole, iconazole, whatever, nystatin. So most likely we are giving this miconazole and nystatin also. Nystatin oral drops, you must have heard, that is for oral candidiasis. Oral candidiasis is also called thrush. So thrush is mentioned, oral candidiasis. So most likely these patients also have oral candidiasis and vaginal candidiasis along. Simultaneously, you can see both of these in patients. So these questions are very clear. You may find 3, 4, 5 recalls for the during the last 1 year, and all of them based on the sign and symptoms, based on the microscopic presentation. Like sometimes it's mentioned pseudohyphae is there, sometimes it's mentioned curdy white discharge is there, and you will look for the history of the diabetes in your patient. Think about Candida albicans, candidiasis, vaginal candidiasis. Then we have another infection, that is trichomoniasis. So in trichomoniasis, that's the organism is Trichomonas vaginalis. It's one of the protozoal infection. Here you will see green frothy vaginal discharge. So when it says fishy odor and clue cells, always think about bacterial vaginosis. Once it says green frothy vaginal discharge, and you can easily see flagella, and those flagella, motile flagella on microscopic slides, it confirms the diagnosis of trichomoniasis. Because I want to show you this one. Here you can see, this is bacterial vaginosis. Bacterial vaginosis, here you are seeing clue cells. These are clue cells. Here you can see, this is Candida. These are pseudohyphae. These are the microscopic examination, microscopic findings of these vaginal discharge. So if you see this pseudohyphae structure, it's a candidiasis. If you see these clue cells, this is bacterial vaginosis. If you see this particularly protozoal infection, you can see flagella, and these flagella highly motile. You can easily see the organism is floating from here to there. So that is trichomoniasis or Trichomonas vaginalis infection. So what we are going to do here, we will see if there's a green frothy vaginal discharge, flagella are there, think about trichomoniasis. And what you're going to do, you will just give gram-negative cover, just like metronidazole. So metronidazole for trichomoniasis as well, metronidazole for bacterial vaginosis as well. But for candidiasis, because it's a fungal infection, you will give antifungal, that is miconazole. And whenever the patient is having this trichomoniasis, always we need to treat the partner as well, because these organisms, these protozoa are highly motile. They can easily go to the partner as well during intercourse. So we will always treat the partners. So let's have a look at the questions. We'll cover all the questions at that one. So here it says a 23-year-old woman presented with vaginal discharge with an unpleasant smell. Now it's mentioned only unpleasant smell. Examination confirmed a homogeneous grayish-white vaginal discharge that has a high pH. High pH means that alkaline pH. Of course, whenever there is an infection, so infection is there because lactobacilli are not working. Lactobacilli are the one which are causing the low pH, means acidic pH. So if it's mentioned high pH, then of course it's an infection, it's a vaginal infection. A saline wet preparation examination of this discharge showed clue cells. So see, we have a clear microscopic examination. So whenever there's a fishy odor, here it's only mentioned unpleasant smell. What if they mention fishy odor? We can clearly guess that it's a bacterial vaginosis infection. It's showing a clue cells, and with application of potassium hydroxide, a fishy smell was generated. Now we have here. So once they add this potassium hydroxide on this microscopic slide, what will happen? There's a fishy smell was generated. So it's which of the following is the most likely diagnosis? So patient wasn't able to say that it's a fishy smell, but we can generate the smell same by putting this potassium hydroxide. So which of the following is the most likely diagnosis? It's a clear case of bacterial vaginosis, right? For bacterial vaginosis, you remember, everyone is quiet and my mic is working, right? Yeah, okay. All
Yes,
of you
got
are okay. So bacterial vaginosis, we have two things to point out here. One is fishy smell, and the very strong clue is clue cells. So clue cell, fishy smell, your diagnosis will be bacterial vaginosis. Now this question.
Doctor, the treatment of Trichomoniasis is Dyson Ford.
Trichomonas vaginalis, you will see here, you will not see clue cells. In trichomoniasis,
No, treatment.
Treatment is just because it's a bacterial vaginosis, we can give gram-negative cover. That is metronidazole. So metronidazole, or if it's contraindicated,
clindamycin. We can give metronidazole.
For trichomoniasis, you can easily give metronidazole to the husband also and wife. Same medication, metronidazole. Okay. Now this,
both have metronidazole,
because these are protozoal infections, so they are highly motile. So we have to treat both partners. Yeah. Now here in this question, a 22-year-old diabetic woman, see, look for the question, 22 years, it's okay, highly sexually active, diabetic women, presented with vaginal discharge and pruritus. See, pruritus, itching is there, she is diabetic, this discharge is milky gray and odorless. So the odor is not there, so forget about this one, vaginosis, and forget about trichomoniasis as well. Milky gray. On physical examination, her vulva was erythematous and swollen. The vagina has white gray discharge that is inherent to the mucosa. Microscopic examination of the discharge confirmed the presence of spores. Now here you will see spores. So what do you think? Which of the following is the most likely pathogen? Whenever it says spores, whenever it says pseudohyphae, whenever it says hyphae or hyphen, all of them represents fungal infection. The spores are of fungal infection. So it's very clear case owing to show the history of diabetes, milky gray discharge associated with pruritus, itching is there, and on microscope you see spores. So spores is mentioned, pseudohyphae is mentioned, hyphae is mentioned. Think about candidiasis. So which of the following is the most likely pathogen? Now they are not asking about the candidiasis, they are asking about the pathogen. So pathogen is Candida albicans. So whether it's a Trichomonas vaginalis or pediculus pubis or Candida albicans herpes simplex, so it's a clear case of candidiasis, and candidiasis is caused by Candida albicans. So it's a clear case. Now look for this question. A 35-year-old.
What is pediculosis pubis?
Pediculosis pubis is an infection. So just like hair lysis, the lyses are there in the pubic hairs, and that can cause pediculosis pubis. Yeah. Extremely in unhygienic areas, or extremely in persons those who are IV abusers and drug addict, and they they didn't have a bath for many years. There you can see pediculosis pubis. Okay. For the next question, a 35-year-old woman gravid of 4 para 2+1 at 26 weeks gestation. Now she's pregnant, 26 weeks. Uneventful pregnancy presented for a fixed 50-gram oral glucose tolerance test. 1 hour later, by finger stick, sample glucose was 8.1. That is quite high. So this patient is actually a case of gestational diabetes. So diabetes is not mentioned directly here. It's mentioned in a way that she has undergone this OGTT testing, and upon OGTT testing, the blood sugars are very high, which is suggestive of the patient is having gestational diabetes. Now, which vaginal infection is she at the highest risk of contracting? Of course, whenever the diabetes is there, it's okay. It's gestational diabetes, but always think about whenever diabetes is there, it will cause the lactobacilli to die, and when there are no lactobacilli, there will be increase in the pH, alkaline pH, and that will promote the formation of spores, and that can easily give candidiasis, vaginal candidiasis. So here, the patient is more prone to get candidiasis. For this question, a 28-year-old woman presented with a history of a copious white vaginal discharge. Whenever it says white, curdy, milky white, always think about candidiasis. With intense vulvar irritation, the pruritus is there, itching is there, irritation is there for 4 days. Now, microscopic examination revealed evidence of pseudohyphae. Now, they didn't mention here spores. They mentioned here pseudohyphae. So now it's a very clear case based on pseudohyphae, based on itching, based on vaginal discharge, white discharge, which of the following is the most appropriate treatment. Now this time they are not asking you the diagnosis. They are not asking you which pathogen is this. They are asking you what will be the treatment. So treatment we know very well. For fungal infection we have antifungals. So we will look for any antifungal medication here. So it's mentioned teroconazole, vaginal cream, azole. All the medicines ending with the azole are actually antifungals. So miconazole, teroconazole, fluconazole, all the azole, that suffix is for antifungal. Metronidazole, of course, it's a gram-negative cover doxycycline antibiotic, ganciclovir antiviral. So we will have antifungal only one here, and that is teroconazole. Okay, you can see there are lots of questions based on candidiasis. So you should cover these topics. You should do very well this all in vaginitis infections. Then we have this one. Here also say, a 21-year-old woman patient complained of severe vulvovaginal itching and discharge. So itching, always itching, think about fungal infection. There are no urinary or other symptoms, and annual pap smear tests have all been normal. So everything is normal. On inspection, vulvar erythema with swelling. There is swelling. Speculum examination revealed a thick white curdy discharge. So curdy discharge, vulvovaginal itching is there. Think about candidiasis. Adherent to the vaginal walls with no odor. And of course, this candidiasis is always odorless. But if it's bacterial vaginosis, there will be a fishy smell. A gross and microscopic examination of the vaginal discharge was done. The wet mount revealed no evidence of clue cells. Of course, no clue cell. It's not a case of bacterial vaginosis. If it's a case of bacterial vaginosis, then only we can say clue cells. Or trichomonas. You will not see any protozoa or flagellated infection. And the QH prep slide confirms several pseudohyphae. So on slide, you can easily see pseudohyphae here. So they have excluded everything here, and they have mentioned you that we have seen pseudohyphae. So it's a clear case of vaginal candidiasis. Which of the following is the most likely diagnosis? Everything is mentioned here. So it's a case of vulvovaginal candidiasis. It's mentioned vulvovaginal, it's mentioned only candidiasis, it's mentioned only vaginal candidiasis, means the same thing. So it's now because vulva is swelled, so the infection is actually spreading towards the vulva as well. So it's a case of vulvovaginal candidiasis. Okay. Here you see, a 48-year-old woman patient suffers from several episodes of vaginal discharge. Now she is old, 48 years old. So she is not very much sexually active and itching around the genital area. The discharge is wide and curd-like. So now it's mentioned curdy discharge. It's okay. She's old age. She is not very much sexually active, but she must be having a case of diabetes or something, because that diabetes can prone her towards candidiasis. Now, the patient's spouse does not have any related condition. So if there is nothing happened with the partner, it means that forget about trichomoniasis. There will be no infection, STD infection here. Microscopy of the discharge revealed budding yeast and pseudohyphae. Now, it's a clear case of candidiasis because on examination, the hyphae is there. The patient symptom might be associated with which of the following conditions? So what do you think? In this patient, what can be the other thing which will give you a clue that this patient, despite of having old age, this patient is presenting with candidiasis. So do you think the patient is having sarcoidosis or tuberculosis or diabetes or lupus? So in which of the following conditions the patient can present with candidiasis? So that's a clear cut. Diabetes, of course. Diabetes is the one which is highly associated, and you know the pathophysiology very well. In diabetic patient, the lactobacilli will die because of the diabetic metabolism, uncontrolled metabolism of the sugar. And for that, the pH of the vagina will getting high, alkaline pH, and the fungal infection is the one which loves to grow on high alkaline pH area. So that's why the vagina will be more prone towards candidiasis.
Dr. Hira, why are you calling her old?
At 48. But if you compare with the 20s and 30s, these women 48, they are towards menopausal stage, right?
Oh,
so they are not very much sexually active. Of course, if you compare,
old is after 80. You know what is the old age in UK? 80 plus.
No. Why I'm saying old? Because when the patient is towards the menopausal age, right, towards the 51, just think about early 50s. Yeah, so they have less libido. So less libido, they of course they are sexually active, but always in your back of mind, if they are very not much, until unless you ask so and you know the frequency and everything, that's okay. But it's a trick. It's a trick for solving MCQs. Otherwise, you will never get a clue. So always these some points which we have in our back of mind, they are actually helping us in making a diagnosis. Of course, not a definitive diagnosis, but it will give you a differentials, right? So it will help. It's a technique to solve actually MCQ. Okay. For the next question, a 33-year-old woman comes to the clinic complaining of recent onset of vaginal itching. Now, vaginal itching is there. The physical examination of the vagina revealed a thick, odorless, white cottage cheese-like vaginal discharge. So, see, there are different patterns which they have mentioned here. Sometimes they are saying white cottage cheese. Sometimes they are saying white, milky white. Sometimes they are saying curdy, thick-like, curdy-like. So, all of these terms are actually for candidiasis. And there is no odor, it means forget about bacterial vaginosis. She has recently finished a course of antibiotic for an upper respiratory tract. So those who have just taken antibiotics, because these antibiotics will kill this helpful bacteria, the lactobacilli inside the vagina, and they can create the pH high and they can cause infection. Or if the patient is diabetic, that can also cause damage to the lactobacilli and cause alkaline pH and cause infection. So here we have a clear history. This patient is not diabetic, but this patient has a history of usage of antibiotics. So which of the following is the most likely diagnosis? So again, you based on the findings, physical examination and on vaginal examination, so white cottage cheese, so it's a case of candidiasis. Multiple questions of candidiasis we have this year. Now this one. A 27-year-old woman presented with vaginal itching is there and an unpleasant smelling discharge. Now it's mentioned unpleasant. Maybe fishy smell, maybe any type of a smell, the patient cannot differentiate it, but if there is a smell, it means there is no candidiasis. Itching gets worse at night and often differs. Now physical examination confirmed a frothy and yellow-green vaginal discharge. You remember whenever it says green vaginal discharge, you have to think for which one? Trichomoniasis. So whenever there is green discharge, always think about trichomoniasis. Her vulva is erythematous and edematous, and the cervix is inflamed and friable. Of course, these are all the symptoms because of the infection. Now, when you do the wet preparation, you will see flagellated protozoa. It's 100% confirmed that it's a trichomoniasis, because if it's a bacterial vaginosis, we will find clue cells. If it's a fungal infection, we will find pseudohyphae, hyphae, or spores. If it's a protozoal infection, it's a trichomoniasis, you will see flagellated, highly mobile protozoa. Which of the following is the most likely diagnosis? It's a clear case of trichomoniasis. Now this one. A 23-year-old woman presented with a yellowish-green malodorous vaginal discharge. Now again says yellowish-green malodorous vaginal discharge. You will think about any, maybe it can be a bacterial vaginosis, it can be a trichomoniasis, but most likely yellowish-green is there, so think about trichomoniasis. A probe for chlamydia was collected and wet prep confirmed trichomoniasis. Now it's clearly mentioned it's a case of Trichomoniasis vaginalis. Now, what they're asking, which of the following is the first step in management? So, Trichomoniasis vaginalis infection. Are you going to give doxycycline to your patient, clindamycin, metronidazole, or follow up wet gram? So, of course, we have to give gram-negative cover, and that's a metronidazole. So, whether it's a case of bacterial vaginosis, whether it's a case of trichomoniasis, think about only metronidazole, first choice. For bacterial vaginosis, if metronidazole is not an option, then we can go for clindamycin. But for trichomoniasis, for the patient and for her partner, we have to give metronidazole. And for candidiasis, antifungal. Any medication that is ending with azole. Think about that one. Okay, this one. A 35-year-old woman attended the gynecological clinic complaining of greenish yellow purulent vaginal discharge. Again, greenish yellow, greenish green is there. Think about trichomoniasis. Now that has started after her period. Upon vaginal examination, there was multifocal rounded macular erythematous lesion like a spotted rash or bruise, and there was a pelvic tenderness. So she is having this spotted rashes or bruise like this erythematous lesion is there. Now that's a new finding in this patient, but it's associated with the infection. And there was pelvic tenderness. Of course, if it's a pelvic inflammatory infection, you may find this pelvic tenderness in your patient. Which of the following condition is the most likely diagnosis? So based on the answer choices, you will decide your answer. So vaginal candidiasis, do you think it's a candidiasis? Candidiasis can never present with this greenish yellow discharge. Bacterial vaginosis, do you think it's a case of bacterial vaginosis? For bacterial vaginosis, there must be clue cells or there must be fishy odor, but it's nothing like that here. Atrophic vaginalis. Atrophic vaginitis is actually happening in postmenopausal women when there is no estrogen, when there is no progesterone. She is just 35 years old. How can you make a diagnosis of atrophic vaginitis? And again, they are having this macular lesion and they have this greenish yellow discharge. So it should be a vaginitis only. And which type of vaginitis? It's a vaginal trichomoniasis. Based on this greenish yellow purulent discharge and based on the erythematous lesion, based on the infection, we can say it's a vaginal tract. If they have mentioned here about protozoa flagellated, something mentioned on wet microscope, then it will be a very clear-cut diagnosis. Other than that, you can also think about this one, vaginal tract. That's the most likely diagnosis. Okay, for the next one, we have to go for the theory. Now we have this. So we have covered all these vaginal candidates and trichomoniasis. Now coming to urethrocoel. So see, urethrocoel, we should not do this urethrocoel alone. Actually, it's a whole pelvic organ prolapse. There we have to cover cystocoel, urethrocoel, and rectocoel. But only for recall point of view, because I have only found recall of this urethrocoel. But you will cover the whole topic of pelvic organ prolapse, where you will see if the bladder is actually coming down from the vagina. You can say the bladder is coming. You can say it's a urethrocoel, it's a cystocoel. If only the urethra sagging down inside the vagina, you can say it's urethrocoel. And if the whole rectum is actually prolapsed through vagina, we can say it's a rectocoel. So we will just quickly cover this one from Amber, so that's very good mention there. But we will focus more on urethrocoel base because we are actually more into recalls. But here the topic you should cover the whole topic of pelvic organ prolapse. So where we can see actually vaginal wall prolapse is there, and this vaginal wall, we have two walls, anterior wall and the posterior wall. So most likely anterior side is associated with urethra and the bladder. So once the bladder is actually protruding and once there is a protrusion of the urethra, so we have two terms. Cystocoel is for the bladder and urethrocoel is for the urethra. How you're going to go for the examination and how you will say it's a urethrocoel, it's a cystocoel, because both of them are very, very unique and very, you can easily differentiate that whether it's a urethrocoel or it's a cystocoel, but you need practice in order to differentiate. So for cystocoel, always you will see the whole bladder is actually prolapsed into the vaginal wall. So there will be a very large, bulge of bladder. But for urethrocoel, when you examine the urethra of the patient, you can see some cells of the urethra. Actually, from urethra, you are seeing a bulge is coming out into the vagina. So if you follow the urethra and you see a small bulge, you can say it's a urethrocoel. But when you see a big ball bulge, then of course it's a bladder. So you have to go for the examination just in order to make a diagnosis. Then rectocele is quite clear because rectocele is on the posterior wall of the vagina. On the anterior wall, we have only two things. One is cystocele and one is urethrocoele. So once the urethra is actually sagging into the vagina, that's a urethrocoele. But once the bladder is actually coming down, so bladder will give you a big ball appearance. So that will be a cystocele. So anterior vaginal wall prolapse, herniated anterior vaginal wall, which is often associated with cystocele, which we say is the descent of the bladder, or urethrocoele, descent of the urethra. So on examination, only you can differentiate because almost the presentation is same. The patient will say the ball is actually coming out from my vagina once I urinate and there's a heavy feeling. Sometimes I feel pain in my lower abdomen. These are the usual complaints. So whether it's a case of urethrocoele or it's a case of cystocele, the patient will say you something like this, that I am having this aching pain while urinating. While urinating, I can feel a small bulge, around the urethra, around my urinating area. So the patient will say something coming out of vagina. Always in a late term, she will always say that something is actually coming out from my vagina. So that we have to differentiate whether it's a cystocele, urethrocoele, or a rectocele, or a complete prolapse where the whole uterus is actually coming out from the vaginal wall. So the posterior wall, we usually see this rectocele, that is the rectum is actually protruding into the vagina. And for the uterine prolapse, you can easily say its whole uterus is coming out. Vaginal vault prolapse, only the apex of the vagina is actually descending down. So, and whole procedentia is the protrusion of the all vaginal wall and cervix beyond the vaginal introitus. Like from the introitus, everything is coming out, or including anterior wall, posterior wall, uterus also. You can say it's a whole procedentia, third degree. So that's the uterine procedentia. So for this, you can do in detail by yourself. I will not go into the detail. What you're going for the treatment. So we just go for the conservative. We will just go for the insertion of vaginal pessary. Pessary can do what? It can help, to support the pelvic organs, but that's a very basic thing, or we just ask for the patient to go for the Kegel exercises. But ultimately what we can do, we will have option of surgery. If the family is complete, you can always ask your patient to go for vaginal hysterectomy, taking out of the uterus, below. No need to go for the total abdominal hysterectomy. We will not open the abdomen and taking out of this whole thing. We'll just remove the uterus from the vagina. That is vaginal hysterectomy is always a preferred option. Even in old patients also, we will never prefer this total abdominal hysterectomy. We will always prefer vaginal hysterectomy. If the family is complete, of course. So let's have a look at the question. It says a 51-year-old multi-parent woman is complaining of urine leakage at laugh or cough. Of course, laughing or coughing. So what is this? Is this a stress incontinence or it's a urge incontinence? It's a stress incontinence. Exactly. Whenever stress is there, she is not able to hold her urine along with feeling of dragging or balloon-like sensation in the genital area for the past 4 months. She's having this balloon-like sensation in the genital area. So when she's touching her down, especially during washing, what she can see the bulge around the urethra. So that's her observation. Now, what we are doing here on examination, like once we did the examination, we found out the tissue around the urethra sags into the vaginal wall. So here it's clearly mentioned, there is ambiguity in that. Here it clearly shows urethra sags into the vaginal wall. So there will be a small bulge. You can easily differentiate that is coming out from the interior wall of the vagina, and actually the urethra is sagging down. So that's a urethrocoele. Once it's mentioned, the big bulge is coming out from the interior wall of the vagina. So that is a cystocele. Cystocele, the bladder is actually coming and there will be a big bulge. Once the bladder is coming out, the urethra will be absolutely normal. There will be no sagging of the urethra at all. But once it's mentioned sagging of the urethra, you can see urethrocoele. And once both are there, sagging of the urethra is also there and cystocele, then it's a urethro-cystocele together. So it can be together as well. But here it's clearly mentioned the urethra is actually sagging into the vagina. So which of the following is the most likely? So of course, based on the urethra, you will go for urethrocoele. You cannot say cystorecto or anterior. It's a clear case of urethrocoele. And once, if it's not mentioned here urethra, based only on the patient finding, you will be confused in between cystocele and urethrocoele. That's why you have to go for the examination, and once you do examination by yourself, you can easily differentiate whether it's a urethra sagging or whether it's a whole bulge of the bladder which is coming out. So you can easily differentiate between two. I have just mentioned one point here. Cystocele occurs when the wall of the bladder presses against and moves the wall of the vagina, and a urethrocoele occurs when the tissue surrounding urethra sag down within the vagina. So just in order to make a diagnosis of urethrocoele, there is only one difference that you can easily appreciate, that is it actually the tissue of the urethra which is coming down. So urethra will be distorted in that condition. So that is a urethrocoele.
Excuse me, Dr. Hira.
Yes, doctor.
Can you please show me from up?
Yeah. This
Question.
one? Yeah.
Yeah. So the urethrocoele will not be visible outside, from the outside, on the outside vagina.
Then whenever the patient urinates, she will feel some bulge coming down. Only on urinating she will feel, because there will be a more bulge when she's passing urine. The urethra will be more sagged into the vagina, so she can just only having a feeling of something ballooning effect. Like whenever I pass urine, she will say something like the ball comes down. And whenever I stand up and this urination is done, nothing is there. Only when I'm sitting down, only when coughing, leaking. So see, there is also one point here: coughing and leaking, stress incontinence. So stress incontinence, of course, is associated with urethrocoele and cystocele, both of them. So only on the basis of the patient symptoms, you cannot say it's a urethrocoele or cystocele. You have to go for the examination. So once you do examination by yourself and you see it's a urethra distorted and urethra is having a bulge, especially on examination, then it's a urethrocoele. And if you can easily see the someone outside, बच्चों के कमरे में बाहर, or once you see this bladder is actually the bladder is having a full ball like appearance on examination. And you especially ask your patient to cough and sneeze or to laugh. So once you see when the patient is having this coughing, the whole bulge is actually coming out. So only on examination you can differentiate.
So the cystocele will be coming only on coughing and pressure, not
on coughing or on urination, during micturition. Yes.
Okay. Thank you.
Then we have okay. So the next one we have
but
to go.
See, urethra is very small and it's already outside.
Yes.
So
but urethra is outside in the introitus, right? In the area in the center, but its tissue is going into the vaginal wall. So you can easily differentiate the bulge is towards the vagina.
It will come out from that vaginal wall. If you produce from that.
Yes. Okay. So for the next one, we'll go for the theory first. Next, we have this pelvic inflammatory diseases. So we'll go for the MTB. Handouts 197. Okay. So this pelvic inflammatory diseases, of course, the name says it's inflammatory diseases. So pelvic infection is there. So any kind of infection, any kind of sexually transmitted infection, maybe bacteria, maybe viral, maybe any protozoal infection can cause this pelvic inflammation also. So the patient will always say lower abdominal tenderness is there. The patient is having pain, abdominal pain, lower abdominal pain. The fever may be there because it's infection. Cervical motion tenderness. So the cervix is quite tender and motion sensitive. Once you touch the cervix, you can easily see the excitement over this cervical area. So that is called cervical motion tenderness. And this cervical motion tenderness, by the way, is present in pregnancy also. So we have to exclude the pregnancy also in those patients who are having this positive cervical motion tenderness. And of course, it's an infection, you will see increased amount of leukocyte, WBC will be increased. So what we will do, whenever the patient is having on examination this cervical motion tenderness, you have to exclude the pregnancy first. Once you are done with this thing, that pregnancy is not there, then you can proceed with the treatment. So what you will do, you will go for the swab. You want to know what exactly infection is this one, and then you will treat that infection. So you will do this DNA probe or nucleic acid amplification NAH testing. NAH testing will give you exactly the organism which is there. Maybe it's a chlamydia infection, maybe it's a gonorrhea, Neisseria gonorrhea infection, most likely any kind of sexually transmitted infection. And you can go for the culture and sensitivity testing, especially of this one. So cervical testing is not the most accurate test for pelvic inflammatory diseases. But we have this DNA probe. Although cervical swab, we can the most accurate is laparoscopy. where you can see, especially if upon examination, upon this smear collection, you cannot find any specific organism, then only you can go for the laparoscopic examination. On laparoscope, you will appreciate whether it's adhesions or something they are associated, something, endometriosis is there, some ongoing, maybe is there any other pelvic organ which is involved. So that can also cause, maybe there are some, maybe there is any infected, cyst is there. So there are a lot of things which you can easily differentiate during laparoscopy when you cannot find anything on cervical swab. So that's why they are saying cervical swab, of course, is the initial one, but that's not the most accurate one. Most accurate one will be laparoscopy, where you can clearly see what exactly is happening inside that cause tenderness, that cause lower abdominal pain and all that. Symptom persists despite therapy. So when you do laparoscopy, when diagnosis is unclear, you cannot able to make a diagnosis whether it's a bacterial infection or what. Symptom persists despite therapy. You have already provided medical treatment but no response, and recurrent episodes for unclear reasons. So happening again and again and again. PID. Look for anything. Maybe there is endometritis, maybe endometriosis, maybe adenomyosis, maybe any other cyst, maybe any tumor, metastatic tumor that is infected, and that can also cause this type of infection. So for all those unclear reasons, we can go for laparoscopy. For the treatment point of view, of course, once you look for the organism and you know exactly which organism is this one, you can go for the treatment. Say, for example, gonorrhea is there or chlamydia is there. So you can give, especially if the patient is admitted in your hospital, you can go for cefoxitin. That will cover, both of these infections, gonorrhea and chlamydia. OPD basis, if you want to treat your patient on OPD basis, you can go for ceftriaxone or doxycycline, possibly with the metronidazole for the gram-negative cover. You can give these two medication, and these two medication will cover both chlamydia infection also and gonorrhea also. And those who are allergic to penicillin or show anaphylaxis to penicillin, so we have for the OPD patient, we can go for levofloxacin, metronidazole, and if the patient is admitted, you can go only for, why we are discriminating outpatient and inpatient, because outpatient will usually take oral medication, and inpatient you can give IV medication. So here you can give clindamycin and gentamicin IV route, those who are anaphylaxis to penicillin. So if it's clearly, the question is clearly asking you, the patient is allergic to penicillin, then only think about levofloxacin as an outpatient, and as an inpatient clindamycin. But other than that, always think about ceftriaxone. So ceftriaxone is the one, or doxycycline is the one which we usually give to our outpatients, OPD patients, if they are having this pelvic inflammatory disorder, diseases. And it's a very good thing that both of these medication, either ceftriaxone alone or doxycycline alone, can cover both of these infections, gonorrhea and chlamydia. Now let's have a look at the questions. Here the question says, a 23-year-old woman who just recently had an intrauterine device fitted. So 23 years, IUD is inserted. Most of the time when IUCD is inserted, the patient is experiencing some abnormal bleeding, some brownish vaginal discharge. Sometime, 10 days after she's coming to you that I'm having fever, the lower abdominal tenderness is there. Why? Because this intrauterine device is a foreigner device, and her body, if she's young enough, like 23 years old, she must be having a very good immune system. Then what will happen? Her body may resist towards this intrauterine device, and infection can be proliferated in her body. So she's complaining of watery brown vaginal discharge and abdominal pain. Which of the following is the most likely diagnosis? So again, based on the answer choices, you will decide. Because once, if I hide all the options and I just give you this question, then you can think only of, okay, it's a brown vaginal discharge. You will just reassure the patient, right? You will say it usually happens when we put intrauterine devices. Of course, your body will respond, and we will counsel the patient in the way that once we put this intrauterine device, you may experience some vaginal brown discharge, but don't worry about that. It will take some time and then it will go on. And you will reassure your patient that might be experiencing some abdominal pain, but that's okay. That's perfectly fine. So if we just hide all the answer choices, so up to here, if you have a case, you may think about only, okay, maybe the case is like this. I have to only reassure the patient. But based on the answer choices, you will decide whether it's a brown vaginal discharge or Vaginitis or Menopause or Diffuse or Prolapse or Discharge or Vaginitis or Vaginitis or Prolapse. Of course not. Uterine rupture is not like that. And it's most commonly in those who just delivered postpartum, when you put intrauterine device after postpartum period. Soon after 72 hours after delivery, if you just keep this intrauterine device, those patients are having the chances, if you're not trained enough, you can rupture the uterus while putting this intrauterine device. But not here in this patient. Of course, this is ruled out. Bacterial vaginosis. Do you think it's
how we can put 74 hours after delivery?
Yeah, this PPIUCD is the one which we usually keep 72 hours after delivery. It's very good option that we counsel the patient soon after delivery. We will keep this mama IUCD.
No, it's at least after 6 weeks. After
No.
the os
No, no.
will be open, they will be
No,
bleeding, invasion and everything going on.
I understand.
How we
See,
can
there are two type of intrauterine devices, but one are called postpartum intrauterine devices, which you have to keep soon after delivery, and you have the option till 72 hours. If 72 hours are gone, you cannot keep the PPIUCD. That is called PPIUCD, postpartum intrauterine devices. And the other intrauterine devices like copper T and all that you can keep after 6 weeks or any time in the life period after menstruation. 1 week after menstruation, you can keep. Right? So there is one device called PPIUCD, postpartum intrauterine devices, which you can keep soon after delivery. The patient is in the delivery room. Soon after the delivery of the placenta, once the uterus is fully contracted, you can keep this.
Soon after delivery, how it will stay? The os will be open. It will stay.
No. How os will be open? Once the uterus is fully contracted, you can keep, because you are you didn't experience this one in your practice. It's a very common nowadays. We are keeping PPIUCD. We are encouraging especially this multi-gravida for this PPIUCD. So PPI, it's okay. It will take some time for the uterus to be back on the 12 weeks or 11. Oh, really? So just go and Google about PPIUCD. It's very common nowadays. Even in Pakistan also, it's very common. This every NGOs, they are very encouraging towards the use of
I
this
wonder how it will stay inside. Tell me, after
see, after delivery, once
uterus is so big, uterus has to involate, they have to bleed.
Yes. So we are keeping this device up to the fundus of the uterus, the top of it, and as soon as the uterus is contracting and becoming the size of 11-12 weeks, it will just be at the neck of the uterus. So it will also involute. Once the uterus involute, it will take time, and the IUCD is coming down, and then it will just fix on this one, the neck of the uterus. So during this 45 Postpartum time period, the IUCD also adjusts herself, itself. So that's a beauty of PPIUCD. So you will keep the PPIUCD on the top of the, on the fundus of the uterus. And once the uterus started involuting, after 6 weeks, the uterus will become 11 week size. And this PPIUCD will be adjusted at the neck of the uterus at that time period. Yes, it's like that. And then the patient is going to experience the thread. Not before, of course. So that's a beauty. Just go on the YouTube and just write PPIUCD and see the video. Maybe you can just recall. It's very common nowadays.
Once I went for this IUCD after my third child. After birth.
So see, that's a normal IUCD that you can usually for the
even at that time, it was not inserted, but it was coming out after 6 weeks. Then again, I went after 8-10 months. Then I got it inserted. So I'm very surprised to hear this.
Yeah, yeah, but this PPIUCD is very common these days. Okay. So coming back to this one. So here it says 23 years. So looking at this one, brown vaginal discharge, what do you think? It's a case of bacterial vaginosis? Of course, it's not a case of bacterial vaginosis. Bacterial vaginosis will be clue cells and fishiodor. Twisted ovarian mass. The patient cannot be just stable like this if she's having twisted ovarian mass. So of course, it's a case of pelvic inflammatory disease, where she's having this because of the intrauterine device. We have the cause why she's having this inflammation because of intrauterine device, and she's presenting with brown vaginal discharge. That's a normal finding after putting this IUCD. And abdominal pain, but if there is nothing mentioned here, fever or something, leukocytosis or any other clue for us, but it's okay. Based on the answer choices, you can easily say it's a case of pelvic inflammatory, because others are very hilarious. You cannot choose them at all. Okay. For this one, a 21-year-old patient presented to the clinic complaining of diffuse abdominal pain for the past 3 days. Now she's 21. She's having abdominal pain, diffuse abdominal pain for the last 3 days. Her history included dyspareunia. Of course, there will be dyspareunia, nausea, several episodes of vomiting. On examination, external genitalia and cervix appears normal. So externally, everything is normal. However, the patient reported cervical motion, adnexal and lower abdominal tenderness. So overall, the patient is complaining about the lower abdominal tenderness. Blood pressure is okay, heart rate is okay, everything is okay, but temperature is 38.4. So fever is there. Fever is there, normal is 37. She is having 38.4. So she is having fever right now. She is having tenderness over the lower abdomen. Most likely she's having dyspareunia. So most likely she's having any infection, pelvic infection. Which of the following is the most likely diagnosis? Do you think it's a pelvic inflammatory disease or a chronic cholecystitis? Cholecystitis presentation will not be like this. Appendicitis, of course, will not be like this. For appendicitis, they should be having a periumbilical pain which is shifted towards the right iliac fossa. That's very typical for appendicitis. For cholecystitis, there is a right side pain, right lower abdominal pain or right iliac pain. For cervicitis, how can we say it's a cervicitis? We don't have any particular clue, and here it's mentioned cervix appears normal. So if everything appears normal towards cervix, you cannot say it's a cervicitis. So it's a case of pelvic inflammatory disease.
Okay, Hira, why not cervicitis? It's saying there is motion of cervix as well.
Yeah. See, cervical motion tenderness is a positive sign for pregnancy also. It's not a disease. It's not a pathology condition. It's just give you one clue. With the infection, if tenderness is there, abdominal tenderness and cervical motion is there, think about infection. But for cervicitis, cervix should be inflamed, right? Because it's an inflammation of the cervix. But here on examination, cervix appears normal. So if cervix is appearing normal, how you can say it's inflamed? You cannot say that, right? Because then you can see swollen, red, inflamed cervix. Then you can say, okay, it may be a case of cervicitis. But this cervical motion tenderness, don't confuse this one, because cervical motion tenderness sometimes it's normal. Even it's normal in pregnancy also. So you cannot say, you cannot totally rely on cervical motion tenderness. Yes, of course, if there is cervical motion tenderness, if there is lower abdominal pain, if there is fever, if there is tenderness over the lower perineal area, then always think about infection. And most likely the infection is pelvic inflammatory disease, right?
Okay, okay.
For this one, we have to go for the theory first. Next, we have Bartholin cyst, 990. Here we will see this MPB step 2 CK 5th edition. See, Bartholin gland cyst, normally it's a normal gland cyst, a normal gland, Bartholin gland. But once it's become infected and of course it's filled with the fluid, we can say it's a Bartholin cyst. So Bartholin glands are located on the lateral side of the vulva. That's a normal thing. They secrete mucus and can become obstructed, leading to a cyst or abscess. So infection is there, associated with pain, associated with fever. Think about abscess, and only if it's swollen and fluid is inside, you can say it's a cyst. So that causes pain, tenderness, and dyspareunia. Of course, there will be difficulty during intercourse. Tenderness will be there. Physical examination show edemas and inflammation of the area with a deep fluctuant mass. So on examination, you can easily appreciate this is a cyst that will be swollen, that will be reddened, having pus inside, inflamed. You can easily say that's a cyst. So treatment is similar to other cyst or abscess. What we will do for the most of the time for cyst, we just do IND, incision and drainage, and you can just marsupialize the cyst, like just open the cyst and suturing its end to end. So it needs to be drained. A simple incision and drainage should be done. If they continue to recur, then marsupialization should be done. Marsupialization means that you just open it and you suture the ends of the cyst with the vaginal wall. Just suture them. So that's a marsupialization. So during IND, the fluid released should be cultured, of course. That fluid which is coming out from the cyst, we will send to the pathology lab for culture and sensitivity. We'll look for any infection. If Neisseria gonorrhea is there, chlamydia is there or not. Whoever the infection is there, just go for the treatment of that one. So here you can see, this is the wall. Intritus is there, and here is a Bartholin gland. So this gland, if the duct is obstructed, it's going to become a cyst. So here you will see most likely 8 o'clock or 7 o'clock position. So if you just draw a clock here, it will show 8 here. So it's an 8 o'clock position. So marsupialization is a form of IND, incision and drainage, in which cyst is open and the cyst walls are sutured to the vaginal mucosa. So you just suture the wall. with the mucosa. You suture the cyst wall with the mucosa. That's the marsupialization. So look for the question here. It says a 25-year-old woman complained of swelling on one side of the labia. Of course, one side is involved. The swelling was first noticed 24 hours ago and has not improved despite warm tube soaking. Normally, when we ask them to sit inside, hot bathtubs or take hot bath sets, usually these cysts will become, shrinked. But despite of this maneuver, the patient is still having the same problem. There was non-tender 3 centimeters slightly mobile cyst mass at approximately 7 o'clock on the right side of the vaginal introitus. 7 o'clock, 8 o'clock, most likely it's a Bartholin gland cyst. So blood pressure is okay, heart rate is okay, temperature is also okay, because just right now it's cyst only. It is not converted into abscess. Once it's converted into abscess, the patient must be having fever. So which of the following is the most likely diagnosis? It's a Bartholin cyst, vulvar myoma, vaginal adenosis, Kegel cyst. So of course it's a Bartholin cyst. Based on the position, 8 o'clock, based on the findings, you can say. But for this skinny duct, you can see if you can appreciate this one. We have this gland, which is above here, just beside urethra. But that gland is not involved because the 8 o'clock position is, or 7 o'clock position is Bartholin gland. So there is one more gland, but it's very small. Even though if it's going to be converted into a cyst, that is not going to cause any harm to the patient because it's a very small gland. But this one is, of course, is a big gland. And once it's obstructed, cyst is there, abscess is there, that will definitely cause dyspareunia and harm to the patient. So here it's a clear case of Bartholin cyst. Okay.
Excuse me, Dr. Hira?
Yes, sir.
What will be in vaginal adenosis?
Vaginal adenosis, honestly, there is no term like vaginal adenosis. It should be vaginal atrophy or vaginal vaginitis. Yeah, it's a recall now. So she just told me vaginal adenosis, but I know there is no term like vaginal adenosis.
Vulvar myoma,
myoma, it's okay. Myoma, we can think of tumor because there's something, cystic mass. So someone can think about tumor, but of course vulvar myoma will be presenting with a big tumor. It's not like this one, which is a mobile mass.
I never heard about this term vulvar myoma.
No, myoma is a simple tumor. It's just like
that is uterine myoma, no? That is uterine myoma.
Uterine myoma is uterus, and if the vulva is involved, like labia majora tumor or minora tumor, you can say the term vulvar because vulva means labia. So labia minora, majora, everything can, all together can say vulvar. So vulval area, it means all things together, labia majora, minora, introitus, glands, everything will be there. So if any one of the, tumor is there, you can just look, but it's a very broad term and it will not give you any definitive diagnosis. Until and unless you can see on histopathology that special labia majora cells are actually tumor cells or minora is having tumor or something like that. But this vaginal adenosis, there is no term like that. Okay. For next one, we have to go for the theory first. Then we have postmenopausal bleeding. Okay, for postmenopausal bleeding, we'll go for MTB step 2 CK book, not handouts. We go to page number 1000. So postmenopausal bleeding is exactly what it sounds like, bleeding after menopause. Vaginal bleeding in a woman who has already gone through menopause, and it is considered, of course, it will not be a normal thing. So we always say whenever there's a postmenopausal bleeding, think about always cancer. Until proven otherwise, we have already proven that there is no cancer on the histopathology, then only you can say it's okay, not a cancer. But once the bleeding TMB is there, always think about endometrial cancer. So it is considered endometrial cancer until proven otherwise. Endometrial biopsy, of course, when you do the biopsy, then only you will get to know whether these cells are malignant cells or benign cells or whatever. So endometrial biopsy is the best initial step for postmenopausal bleeding. So usually recalls are based on this point. Endometrial biopsy is best. So postmenopausal bleeding itself is usually self-limited and management is limited as well. The main objective is to rule out cancer. Our whole thing is just to rule out cancer. Once the cancer is ruled out, you can easily, control this PMB, because if it's endometrial hyperplasia, you will go for hysterectomy, total abdominal hysterectomy. So let's see the question. Here it says as
But Dr.
57.
Hira, excuse me, sorry for interrupting you.
No,
This
no.
uterine fibroid will also present with the
See,
female.
uterine fibroid are actually there once there is fertility. Once the fertility age is gone, those fibroids will become shrinked as well. They cannot do anything because the whole process of becoming mascularization is only during menstruation. During menstruation, when once the uterus is actually preparing bed for the baby, the fibroids are also, growing higher and higher. That's why always during pregnancy, the fibroids are also growing like a baby. But once the baby is delivered, the fibroids will get shrink. And now here we are talking about postmenopausal. The postmenopausal uterus is already shrink. Whatever there inside the uterus, there is no
Oh,
estrogen, there
but
is
we
no
also have
progesterone.
fibroids without pregnancy.
Yeah, without pregnancy, but only in the age of fertility age. Once the fertility is gone, once we don't have estrogen, progesterone, those fibroids will not do anything. Those fibroids will also become, fibrosed. They will be shrinkage. They cannot do any further bleeding. Are you getting me? Because once the stage of menopause is there, the whole uterus is shrinked. There will be no elasticity. There will be no effect of estrogen on the uterus, and and estrogen is the one who is actually promoting the fibroids also. So once there is no estrogen, even though fibroids are there, they will be shrinked enough. They cannot do any harm to the patient.
Okay.
They are only talking about postmenopausal, but of course,
So,
before
no.
menopause.
So after, if a woman she has hit the menopause, then she will not develop fibroids anymore. Huh?
Yeah, that's what we are saying. It's likely to be, we have to check for the PMP what is exactly the cause. If it's a cancer, then it's a cancer. If it's a fibroid, we will rule out that one. Again, that in those patients, you will also say go for the hysterectomy. You don't have any other choice. Say, for example, if you're talking just now, if the patient is committed menopause and 1 year after menopause, maybe the fibroid is the reason that can cause. Maybe that can cause, but it's very unlikely. But we may find, of course. Anyhow, both of the treatment, we will go for the biopsy, we will think about, we will see, and we will do the hysterectomy. So we don't have much options here. So for this one, a 57-year-old menopausal woman, now she is menopausal, presents for evaluation of postmenopausal bleeding. Now she is 57 years old. She is morbidly obese, hypertensive, and diabetic. All the comorbids are there. Endometrial sampling showed complex endometrial hyperplasia with atypia. Now see, her histopathology has already done. She has undergone already this endometrial sampling, and sampling result is showing atypia, endometrial hyperplasia. So let me take you to this one so that you will have a clear idea what we have to do if we have this endometrial hyperplasia atypia. It's here one. Here. So endometrial hyperplasia is actually carcinoma, often coexists. The majority of the cases, it's chronic exposure of the endometrium to unopposed estrogen. And here we'll see two things: hyperplasia without atypia and atypical hyperplasia. So this one is benign atypia, but atypical hyperplasia is the cancer one. So what we are going to do here, especially see all the risk factors are here, the same in that patient, obese, PCOS, maybe tamoxifen therapy, she's on this one, maybe early menarche is there, late menopause is there. So how we are going to manage these patients? We have only option of hysterectomy. And this important line, atypical hyperplasia has a high risk of progression to endometrial carcinoma. So just now it is atypical, but it will take no time to convert into endometrial carcinoma and a potential for existing invasive disease. So that's why hysterectomy is the only treatment of choice in these patients. Those who are having postmenopausal bleeding, and once you do the endometrial sampling, it will show atypical hyperplasia. Always think about that this atypical hyperplasia can anytime lead into endometrial this one cancer carcinoma, and that is a high time when we offer hysterectomy. Other than that, we will be in trouble because when metastasis is there, then what will happen? We have to go for radiotherapy. We cannot, we cannot remove all the pelvic and all the things. We have something in our hand. Once atypical hyperplasia is there, just remove the uterus. Once the cells metastasizes, then we don't have any other option. That is called debulking, right? Then we only go for the debulking. So now here, which of the following is the most appropriate treatment? So once atypia is there, endometrial hyperplasia is there, are you going to go for myomectomy, or you will go for oral progesterone, you will go uterine artery embolization, or total abdominal hysterectomy? So there was one line which was in MTV which clearly says that once atypical hyperplasia is there, go for hysterectomy. That will be the treatment of choice. So it's a very clear line. We'll go for total abdominal hysterectomy. This is going to add value to your patient. Now this one, a 65-year-old post-menopausal woman complains of
Dr. Hira,
yes, sir.
This uterine artery embolization treatment for PPH, no?
No, uterine artery, that is for PPH, of course, not here
For
in this
PPH,
57. No? Yes, that's for PPH.
And oral progesterone?
Oral progesterone also, once we want, once you want to give HRT treatment or some symptoms of the, menopausal symptoms to control. But here, it's not like menopausal symptom. It's clear case of endometrial hyperplasia.
Here cancer.
Yeah.
No,
okay. A 65-year-old postmenopausal woman complains of on and off vaginal bleeding that started 2 months ago. Now she is highly menopausal. She's in a later side of this menopause. The amount of bleeding is mild to moderate of fresh blood. The woman is diabetic, hypertensive, and obese. She has used hormones replacement therapy to control postmenopausal symptoms. So she was actually using HRT, and we have already done this before. That once the patient is on HRT, there will be more chances of having endometrial cancer in those patients later in life. So body mass index is obese. Which of the following investigations is essential? What you're going to do next? Are you going to go for pelvic MRI, or you will go for pelvic ultrasound? You do endometrial biopsy, or you do tumor marker? What you will do? Well, once you want to diagnose why she's having this postmenopausal bleeding, we have already done this MTB. The best initial diagnostic test for PMB is always endometrial biopsy or endometrial sampling. See, there was a clear line in handouts. No, not in handouts, this one. So back. 990, right? No. Is that 1,000? This one. See, endometrial biopsy is the best initial step for postmenopausal bleeding. So this line is clearly saying this one. So answer, we have this one. So here what you're going to do for the postmenopausal symptoms, you will go for endometrial biopsy or endometrial sampling. So this is all about this. So thank you so much for joining. That's all for today. So inshallah, see you tomorrow. Thank you, everyone.
Thank you, Doctor.